Hi, I'm Dr. Laura Wilton, one of the GP partners up at Arthur Medical Centre. I just wanted to start by saying thank you for taking the time to listen to this and to understand what's going on both in the practice and nationally. The Arthur Medical Centre is a place that we're all really passionate about, and it's great that so many of you care too. I've been here 15 years now, and we're at the most challenging time I've ever known in general practice. We want to continue to offer you the best care we can within the constraints of our contract and therefore finances. We really appreciate your support to work with us to look after our community. I'm now going to hand you over to Azim, our business managing partner, who's going to go through some information that we hope you'll find useful.
Thank you very much, Dr. Wilton. So my name's Azim, I'm the business management partner. And just thank you for taking the time to view this update in advance of the next patient meeting. We intend to hold the next patient meeting on the evening of Friday, the 12th of April at 7 p.m. And the link is available at the end of this presentation. So if you would like to join, please view to the end and you'll find the link, and the link also to submit questions in advance of that meeting. So this meeting that we've organised is the second in what we hope will become a quarterly series of practice meetings for patients. The previous meeting was delivered on 21st of June, and the feedback that we got from patients at that point was that they really appreciated the time that we'd taken and the opportunity that we'd given to communicate directly with the partners of the practice. We'd like to do this more often, and therefore we've organised this next meeting for the 12th of April in that spirit. The feedback that we got from the previous meeting tended to revolve around understanding who our team was and the various roles that are around the practice and what services they can offer to patients. And I'll endeavour to share some of that within this presentation. A video of that meeting is also available on our YouTube channel at this link that's shown here, or if you go to the homepage of our website, arthurmedicalcentre.co.uk, it'll be shown in the front page and you can view that video there. So in this short presentation, I'm going to provide some general practice insights, so some general sector background into just an insight into primary care, just to give you an idea of what's happening across the sector and also in the practice specifically. We're then going to look at some patient feedback that we've received over the past few months, which is mostly relating to accessibility and services. And then we'll talk about some of the future plans that we've got and some of the challenges that we expect to face in the next year or two. So from a general perspective, most general practices are independent, small or medium-sized business units within the framework of the NHS. Patients sometimes view the NHS as being one single organisation, and that's understandable viewed from the outside, but the truth is a little bit different from that. I usually compare the NHS to being like the United States of America, where from the outside it looks like one united country. But actually, you've got a union of 50-odd states who operate independently with their own legislation, with their own governance, and with their own relationships between each state. The NHS is similar to this. So you have primary care, you have secondary care, you have NHS Digital, NHS Estates, and all of these business units operate independently of each other within an NHS framework. So general practices are usually independent, contracted, small to medium-sized businesses that are then contracted for NHS services on a national contract. This is done by a local commissioning body, which in our area is the Derby and Derbyshire Integrated Care Board. So there's 114 practices within Derby and Derbyshire. List sizes vary from practice to practice and demography varies from practice to practice. Arthur Medical Centre is classed as being a medium-sized practice with our size of a patient list. Each practice has its own way of running and has its own policies and procedures. And just to give an idea of where we fit into the bigger picture, primary care as a whole accounts for about 8.5% of government health expenditure. Now, the sector's changed quite a lot in the last few years. Since 2015, there's over 1,000 practices have actually closed and disappeared, and this is something that is still happening today. Just last week, a practice in Nottingham actually handed back their contract and closed their doors. Since 2015, over 2,000 GPs have left the service, and they've either retired or they've gone on to work elsewhere or they've gone abroad. Conversely, we've added more than 6 million patients to our books, and our consultation levels are about that where half of the population could have been seen each month in general practice. Now, as I've mentioned, we account for about 8.5% of funding. We account for 5% of NHS staff. One issue that we face in general practice is that in real terms, the GP contract has actually not been increased in line with costs. And in fact, in real terms, it's been eroded by £620 million compared with 5 years ago. The government has committed £1.4 billion of funding to the NHS, but the practice is not allowed to use that to recruit more GPs or nurses. So specifically for our practice, the patient list size as of the 1st of March is 9,170 patients. And as I said, that puts us on a medium-sized practice footprint. To compare that to previous years, you can see here that we've gone up from 8,904 in 2020 up to 9,170 in March 2024. So we acknowledge that our list size is increasing. Now, the way that the GMS contracts general practices, we're not actually allowed to refuse registrations. We're not allowed to close our books to new registrations unless we have some sort of business critical problem, such as loss of a building or something like that would give us a reason to do that. So whatever problems we're facing, we're not allowed to stop taking new patients on. One of the indicators that we use to measure how busy that we are is telephony traffic. So on average, we're answering about 249 calls per working day. So over a week, on average, that's about 1,247. That's an increase of 9% over the same period last year. Last year was an increase of 10% over the previous year in 2022. So our traffic is actually increasing and we're getting more busy year on year on year. One thing we're not recording is the amount of footfall that we get at the front desk, and that's something we are looking to do at some point in the near future. Now, telephony, our current telephony system is a fixed line system of telephony. So we have 11 telephone lines coming into the practice. Our provider is a cloud-based provider, so our recording and our software, etc., is held on the cloud, but we are limited by those 11 lines. And what that means is that only 11 lines can be engaged at any one time, whether that's patients phoning in or GPs phoning out. Therefore, this comes to a problem in terms of congestion for the telephone traffic that we are receiving. Our reception or care navigation team currently has 9 members in that team, which equates to about 211 hours of resources it mentions here. And we have reflected the increase in traffic over the past couple of years. We've actually increased that team by 10% to reflect the number of patients that are calling through. In terms of appointments, over the last 4 weeks, as it says here, we provided a total of 3,713 patient appointments. Of those appointments, 2,412 of them were GP appointments or ACP appointments, which equates to about 121 appointments per day on average. Now, an ACP is an advanced clinical practitioner. This is a practitioner such as a nurse or a physiotherapist or another member of a clinical team who's sat additional qualifications. They've sat a master's degree and they're a prescriber, and they're able to deal with many of the complaints that a GP can also deal with. So many of your minor illnesses and day-to-day work that a GP can deal with, an advanced clinical practitioner is able to help with just as well. The remainder of the appointments were with other practitioners such as nurses. Face-to-face appointments are something I get asked about quite a lot as a practice manager. Typically around 60% of the appointments are face-to-face. With routine calls or routine requests for appointments, we usually give the patient a choice of whether they'd rather have a face-to-face or a telephone appointment, and the patient then makes that choice and we honour that. The exception would be the on-call or emergency list, where that is majority a triage list, so it's done by telephone, and a doctor will ask you to come in and see them if they feel that you're needing it. So in terms of safe levels of working, the British Medical Association, the BMA, publishes guidance as to what it feels is a safe level of working for general practitioners. So if you think about a lorry driver, for example, a lorry driver has a tachograph in his cab, which then monitors how long he's driving, and when he reaches a safe level, he has to stop driving, or else it will be illegal for him to continue. So we recognise with lorry drivers, there's a safe level of working where they shan't be able to drive beyond because they become less safe. This is also the case with GPs, but there isn't a tachograph for GPs. So the guidance given by the BMA is that a GP can safely deliver up to 28 consultations per day. This is also in line with some studies and analysis done by the UK government about 2 years ago. So in November 2022, the practice introduced a capped system of appointments to reflect that BMA guidance. In terms of our resources, we have 3 GP partners who own the practice along with 1 non-clinical partner. We employ 5 salaried general practitioners within the practice, and we've got appointments with 2 advanced clinical practitioners in the practice as well. So in terms of total resources, we measure these in half-day sessions or shifts, and at the moment we've got 47 half-day sessions or shifts in the practice, although the work very often extends beyond that. It's not unusual for a doctor to be here maybe 3 or 4 hours over their shift time. Other resource, at the moment we've got 5 practice nurses and 2 healthcare assistants. We also have a GP assistant who works to support the works of the GPs and to pick up some of the patient work on their behalf. In total, that's 177 hours of other resource, and that compares to 131 hours of the same resource in 2022. So again, we've increased that resource to try and match the demand that we're receiving. A few years ago, the government policy towards primary care was that they would introduce a new scheme called primary care networks. Primary care networks were brought in to bring practices to work together collaboratively with each other to share resources, which was a sensible idea. So Belper Primary Care Network was formed in partnership with Whitemoor, with Appletree and Riversdale Surgeries in Belper and in Duffield. And the 4 practices work collaboratively to provide services to patients across our area. The government has provided funding to the primary care networks to provide access and capacity through some of these different roles. So the PCN provides social prescribers. We have access to 2 of these through the primary care network. And a social prescriber is there to help patients with life matters. So things like bereavement or debt or the kind of things like loneliness that doctors can't medicate. That doctors try to treat, but there comes a line where they have to be helped by somebody else who's a specialist in that area. We have a nursing associate who works in the practice 2 days a week from the PCN. We also have 2 mental health workers who visit the practice on a weekly basis. The practice also accesses the acute home visiting service for housebound and elderly patients. We have first contact physiotherapists who work from the practice each week. And this is a really beneficial post because if a patient has a problem with muscles or joints, etc., that would be referred to a physiotherapist, instead of going to a doctor to be referred to that service, they can self-refer to the first contact physio and go straight to that practitioner. We have an occupational therapist who works with people in terms of their occupation, in terms of medicine, fit notes, I beg your pardon, when they're off sick. We have a specialist diabetes nurse through the PCN, which can help us focus and specialise care on patients with this particular problem. We've also got a dedicated clinical quality lead within the PCN who helps us in matters of compliance and in terms of advice on clinical matters. In October 2022, the government withdrew the contract for enhanced access from practices. So Arthur Medical Centre used to be open on a Saturday morning for appointments, but that contract was withdrawn by the government in October 2022, and it was passed to the primary care networks who now operate that service. So the primary care network operates that service from a single source in Whitemoor and Belper, but we felt that with the transport difficulties and with our patient demography here in Horsley Woodhouse and surrounding areas, that we had to have 1 session per month at very least here in the practice, and that's what we managed to achieve. So we still provide 1 in 4 Saturdays. We have a session here with nurse practitioners or other practice consultation types here in the practice itself. So in terms of how GPs spend their day, about 60%, I beg your pardon, is spent in direct patient care. So this is patient appointments. But there's indirect patient care, which amounts for a lot of time outside of that, as well as administration. So when a patient sees the doctor will have some work to do outside of the consultations. They'll have some clinical administration. It might be referral paperwork. It might be related to prescriptions. It might be related to other matters that need to be addressed for that patient's consultation, but out with the consultation itself. And that is an increasing unseen amount of work. Like any other profession, doctors have meetings that they have to attend. They have to attend safeguarding meetings. They have to attend appraisals, etc. And then doctors as well spend their time in other matters such as training. They have to maintain their registrations and they have to complete mandatory training. So moving on to patient feedback. The recent feedback that we've received from patients over the past few months is really centred around three main areas, and they're all to do with accessibility. So the first area is accessing the practice by telephone. The second area is making an appointment. And the third area is when we signpost them to other services, so for example, a local pharmacy or NHS 111. So in terms of telephony, we appreciate that our fixed line telephony system does cause congestion and that this is often a source of frustration for patients. Now we're addressing this by installing a new approved set of telephony with a new provider, which we've been given a date at the end of March this year for this to be installed. Now that's largely dependent on the provider, but that's the date we've been given to work towards. Now, the benefits that this will bring to patients will be that there'll no longer be a limited queue of 11 in the queue. There will be an unlimited queue and there won't be an engaged tone, so patients won't have to go through the experience of redialing over and over and over again on a Monday morning or any other morning trying to get onto the queue. They'll go straight onto the queue. The queue may be longer than it used to be, but at least you'll be onto the queue and you won't have to sit and keep redialing. And importantly, the system will also feature a callback feature. So patients will be able to press a button to select an option, and then the system will call them back when they're first in the queue. So you won't have to sit listening to the hold music and sit for X amount of time waiting on your place to come in the queue. The system will also give you a second chance if you don't pick up the first time. So it will give you two chances when it calls through. Importantly for the practice, this means that if we have something that means we can't operate as we normally do, so for example, a power outage or a flood or even another pandemic or something that causes us to restrict flow of patients in the practice, we can have people working from other locations, even working from home, and they'll still be able to work in telephony with the full amount of resource that they have here in the practice. So in terms of the appointment system, at the start of November, the practice began to use an all-on-the-day system of appointments. Now, we introduced this to deal with an expected increase in winter demand. Every year there's an increase in winter demand for urgent appointments, on-the-day appointments, and this is typically for the type of infections or problems that come up during winter periods. Now, we introduced this after we were advised that there wouldn't be any of the usual funding that's available to practices. So every year, NHS England in the past has provided a pot of funding to practices to bring in locums or to pay for overtime to ensure that we've got enough capacity to keep going with an increased level of demand. That was not made available to us this year by NHS England, and it looks like that will not be made available to us in future. So we had to bring something in to make sure that we could manage the increased demand for on-the-day appointments. The information received and the feedback received from patients was that the system was working well for many of them. The majority of feedback that we got relating to the appointment system expressed satisfaction with the fact that patients could get an appointment on the day they wanted it. We decided to keep going with this appointment system based on that feedback, but also it was easier for us to manage in terms of managing clinician absence. So during the winter and the early part of the year, it's not unusual for doctors to go off sick or for practitioners to go off sick with the same complaints that patients have. And it meant that we could respond to that and we wouldn't have up to 30 patients that we'd have to reschedule. Now, prior to the on-the-day system that we operated, we ran a pre-bookable system of appointments. So we've always had an element of on-the-day with an on-call doctor for emergencies, but we operated a pre-bookable system of appointments. The feedback that we received during that period was actually that patients were unhappy with that system, mainly because the level of demand that we get meant that the patients could not get an appointment because we were always full, 4 to 5 weeks into the future. And as soon as appointments became available, they were snapped up by patients straight away. Another thing that's in our thinking is that NHS England now targets GP practices for all appointments on a target of appointments being seen within 14 days. And that's not a monetary target, that's a compliance target. It's something that they expect us to comply with, which then will affect the way that we administer and present our appointments to patients. So in terms of what we're doing with the appointment system, we frequently review it and we revisit it. We discuss it with the patient participation group, and we adjust the mix of appointments for urgent on the day and the pre-bookable appointments that doctors can make when they have follow-ons. So if a doctor wants to see you in a week or 2 weeks or 3 weeks, the doctor can book you an appointment for that. So we do adjust that mix to try and meet the patient needs against national agendas. We also try to keep our unwell and vulnerable patients foremost in our mind, and those are the ones who we try to cater for because they have the greatest need. We're aware of things like medicine reviews that can cause an amount of frustration, and we're working on making those more efficient and accessible, and we're hoping to share some news on that soon that will make these a little bit easier to deal with. We've considered other ways of releasing appointments. We continue to do so at different times in the day, and that's something we're certainly looking at. We've also considered other things like artificial intelligence triage tools. We've also looked at online triage tools. We're continuing to look at technology to see where this can help us, and we'll share news on that as and when we can. So the question might be asked, why are there difficulties with access, and why is that the case now? One reason is the pandemic, but it's not the only reason for this, but it certainly has changed the way the general practice operates in general. Patient demand and expectations have changed a lot in the past few years, and part of that is the fallout from the pandemic, so there's more health anxiety around, but patients generally need they need more reassurance, and also they feel that they need to see the doctor more for their problems. Hospital waiting times also have an impact on us. So as you'll have seen in the news, hospital waiting times are at a record high. And that has an impact in general practice because those patients need to be cared for whilst the hospital is waiting to see them. So an example of patients who need a joint replacement, for example, that patient will need to be cared for quite intensively in the run up to their appointment, which could take some time. So, for example, they're going to need medicine reviews for pain relief more regularly. They're going to see the doctor more regularly to see them about their condition. They're going to need occupational therapy if they work and they need to be off work. All of these things impact on the service and come to us further down the line. There's also an increasing amount of complex problems. So patients present now with more complex problems and with different things that they had before. A couple of other things that impact on times, unseen levels of administration. So when I mentioned in an earlier slide about so many thousand GPs had left the service in the last 5 years, at the moment there's a lot of trainee GPs, so registrars and students that are in the system who won't be online for a few years yet, but they are coming up through the education system and through the trainee system. When these students and when these registrars are in practice, they require a degree of educational supervision from established and existing GPs, and that takes their time. So they bring a resource because they bring appointments, and in the future, it really will be beneficial. But in the meantime, we have to accommodate their educational needs, and they need supervision in their roles until they're fully qualified. One of the core problems that general practice faces, and Arthur Medical Centre is no exception to that, is that the GP funding that we receive has not risen in line with costs. So like yourselves, our fuel bills, our energy bills have doubled in the past year. Our telephony bill is about to double. Our staff costs are rising incrementally every year with increases in the minimum wage, and we're not being recompensed for that in our funding. So in real terms, the practice actually takes a hit to funding every year, and we're earning less and less money as a practice. We're bringing in less revenue every year. Therefore, we're simply unable to hire additional staff. Quite often I'll speak to patients and they'll say, well, why don't you hire more doctors? Why don't you hire more care navigators? And that's why we just don't have the funds to enable us to hire additional staff. The crux of the issue is that supply does not meet demand, and at the moment it can't because demand outstrips it completely. So one of the things that we're trying to do to work for the future is our practice extension. So as you may know, we're expanding the building of the practice to provide an additional 6 clinical rooms. It'll also encompass a new downstairs waiting area for patients and a downstairs reception office that can be used to greet them. There'll be improved access at the rear of the building, and there'll be a ramp for those with mobility difficulties to enter. We're also looking to improve and redecorate some of the existing structure of the building as well, which really could be doing with it at the moment. So the question could be asked, why are we building? Why are we spending money on building when there are so many challenges that we're facing at the moment? The first reason for that is that the funding that we receive for building is from a separate pot of NHS funding. We could not use this money for staff or for other purposes. It's an NHS estates fund that we had to bid and apply for, and which we won. So it's not something that was guaranteed to us, and it's something we had to try quite hard to get. That funding is part funding, and the shortfall in that is then made up by the partners. What we need to remember as well is that the problems that we have just now will not be solved by staying as we are, and we need to look to the future. What we hope is that the funding problem will not be a permanent problem, and that in future we'll be able to bring more people into the practice. And we need to think about how that looks now, because we're already at capacity. So our patient list size has grown in a way that we need more clinical space. And also we have these allied health professionals that I mentioned from the PCN, such as the social prescribers, nurse associates. Although these are great in complementing doctors' roles, they need space, they need their own rooms, and we need to be able to house them. And for us to be able to do that, we need to have more space. We can also host visiting specialists, such as consultants. We can host, hopefully in the future, other clinics such as community phlebotomy, midwives, more physiotherapy. We can provide more placements for GP registrars and medical and nursing students, which again builds for the future. And this is really why we're extending. But if I had to summarise it in one key statement, we know that patients want to receive high quality care from a local service, a team who knows them, with a wide range of service and skills in a location that they can access conveniently. And we want this as well. We want this for our patients, and this is why we're extending and committing ourselves to the building, because this is the service that we want to present to patients. So looking ahead at the next couple of years, our challenges really are as follows. Firstly, patient demand and expectations. Patient demand is at an all-time high, and at the moment it's increasing, and the expectations of patients are changing as well. They increasingly expect immediacy. They increasingly look for a very quick fix to something that in the past they may have been content to wait for. Our contractual terms and funding are a real problem for us. So our funding increase that's being imposed upon general practice for the coming year is 2.2%. Now, 2.2% to our practice is around £20,000. And whilst that may sound like a lot, it really isn't. And to give you an example, our staff costs alone will increase by more than £20,000 this year. So the 2.2% increase in real terms is actually a loss for the practice and actually squeezes us even further. Another challenge that we'll have is our staff resource. We need to think about the well-being of our staff, because with the current level of demands, they've been worked very hard. GPs and other practice staff have got more work to do than ever before. And as Dr. Wilton said, it's the most challenging period of time that many of these clinicians have ever worked in. We also need to think about the morale of our staff. So by the very nature of our role, when we meet patients, they're not going to be at their best. They may be frustrated, they may be uncomfortable, they may even be distressed by their problem and by their symptoms. And that means that when we speak to patients, quite often they can express frustration to whoever they're speaking to. That can have an impact on staff, and it is having an impact on staff in terms of morale and retention, because if a member of staff is unhappy, they're going to look for another role and they're going to leave the NHS, and that makes it harder to recruit because there's less people out there to recruit in the pool of candidates. It also drives up sickness absence, makes it harder to get local resources, etc. And that's another challenge that we have, is our staff resources. So what can patients do to help us? The first thing that we would ask you to do is to look after your own health and that of others. We all have a responsibility to look after our own health and to take care of ourselves and those around us. And that's what we asked you to do, is that you look after your own health and keep yourself well and take responsibility for your own health. Please consider your impact on staff and on the system. So, for example, if you have an appointment that you insist on having for a GP, when a physiotherapist or even a pharmacist could have dealt with that, then that takes away an appointment that another patient can have. So please consider your impact on the service. Patient feedback is very important to us. We do take it very seriously. And this, for me as a manager, is how we can learn to improve. It is when patients tell us when they think that we've fallen short. We ask that that's provided in a constructive way and through appropriate routes, rather than being expressed in an angry fashion to the care navigator at reception or a clinician. And this can be submitted in writing to the practice. We have established complaint processes, or you can even just ask to speak to the manager and I'll get back to you as soon as I'm available. You can participate. So the patient participation group is a valued resource that we have. This is a group of patients who signed up to support the practice, and effectively they're critical friends. They're the friends of the practice who want the best for us, and they keep us right by helping us realise where we could do better. This is very important. We encourage you to get involved with that. We also ask you to be prepared to consider alternatives. What could be a better route for help with your problem? Is this something that a pharmacist could solve for me? Is this something that I might be better off speaking to 111? Is it something that the hospital are dealing with for me, in which case the hospital are the best people to speak to us about? And also to be prepared to accept that when we signpost you from the practice. So if you contact the practice and you ask for an appointment and we say this is probably best served by NHS 111 or a clinical pharmacist or a physiotherapist, please be prepared to accept that suggestion and to go down that route. If the practice is full and we're not able to service demand, we will ask you to call 111, who will then signpost you to a solution for your problem. Please be prepared to accept that. And also help us to be efficient when using our services. A certain amount of time is allocated to GP appointments. We're not one of these practices who restrict appointments to one problem, one appointment, but we do have constraints and we do have other patients to see. What we'd ask is that you try to be efficient with your use of our time, as we are, and that you try to help us through being efficient and also through managing our time effectively. So finally, I would like to invite you to join us for our patient meeting, which is on Friday, the 12th of April, via Microsoft Teams at the link that's shown here. This is an open patient meeting for all patients of the practice. And the reason that we have this in Microsoft Teams is because, quite simply, it's easier for us to present and it's easier for everybody to get their say, and we can fit everybody into one virtual space. We don't have the physical space to fit patients into in the practice. What we would ask is that if you have questions that you want to put to the practice, that you do this in advance of the meeting where you can, and that you submit the questions via the Contact Us web form, which is on the website. So if you go to the front page of the website, arthurmedicalcentre.co.uk, there's a button to submit questions in advance of the patient meeting. We'd ask you to use that. We can then prepare responses to your questions and have the data to give you the full answer to the question that you're asking. The link for Microsoft Teams is shown here, and we would encourage you to attend and to spread the word. Thank you very much for your time, and thank you very much for your attention, and we look forward to meeting you and to seeing you at our patient meeting.